Hello, my name is Paul Fletcher. I'm a periodontist and an associate clinical professor at Columbia University, and I'd like to thank Dental XP for inviting me to speak with you on the management of peri-implant disease. I'd like to begin by saying that I think modern-day dental implants are among the most significant advances in the history of dentistry, and that implants make up a significant part of my practice. Having said that, peri-implant disease has become one of the more controversial topics in the field of dental implantology. There are extremely well-respected researchers and clinicians who state peri-implant disease is an infrequent occurrence, while there are equally respected researchers and clinicians who feel we have a problem. I'm one of those who feel we have a problem. At Columbia University, where I teach periodontics and implant dentistry on a postgraduate level, hardly a week goes by when a student doesn't approach me with another case of peri-implant disease. And in my private practice, where literally half the new patients that we see have some form of an implant-related problem, the number of cases of peri-implant disease have also been rising. The research seems to also indicate we have a problem. Research says as the number of implants that have been placed increases, and as the number of years implants have been in place increases, and as dentists with different skill sets are now placing implants, the incidence of peri-implant disease has been rising, and the prevalence of peri-implant disease is increasing. But the research on peri-implant disease is confusing because study methodologies vary. Different studies have different thresholds for peri-implant disease. Different surfaces and different designs are often equated. And some studies look at patients with peri-implant disease, and other studies look at implants with peri-implant disease. And finally, some studies implicate implant or equate implant survival with implant success. So, if you look at this case after 13 years, you can see what it looked like originally and see what it looked like after 13 years. Well, the case definitely survived. Is it a success? Well, that's open to discussion. But does it need treatment? Yes, it definitely does need treatment. As I mentioned, some studies look at patients with peri-implant disease, while other studies look at implants with peri-implant disease. This is a study by Franzen, who is a member of the Lindy Group, and what they did is they looked at 662 patients with 3,400 implants, and they assessed the implants over the course of 5 to 20 years. And what they found is 185 of the 662 patients, or 28% of the patients, had one or more implants with progressive bone loss, whereas 423 out of the 334 implants, or the 3,400 implants, or 12% of the implants, showed progressive bone loss. Thus, if I was a speaker or somebody wanted to emphasize that peri-implant disease is a real problem, I would look at the number of patients, 185 of the 662, or the 28% of patients with peri-implant disease. Whereas I wanted to say peri-implant disease was not that much of a problem, I would look at the number of implants, 12% of the implants in the sample that had peri-implant disease. In any event, if your patient has a problem, you have a problem. So let's start at the beginning and let's talk about the definition of mucositis and peri-implantitis. Mucositis is a reversible inflammatory reaction in the soft tissues surrounding a functioning implant. The key word here is reversible, whereas peri-implantitis is a destructive inflammatory reaction affecting the soft and hard tissues of an implant and function. Thus, the bone is also affected. And this is more difficult to reverse than mucositis. Now, from a historical perspective, we've sort of been lulled into complacency by the early Brannemark research, or the early implant research, which essentially said is periodontal indices, such as bleeding upon probing or pocket depth, when applied to the peri-implant mucosa, may be of little clinical significance when measuring the success or failure of an osseo-integrated implant. And peri-implant disease was rare. Attached gingiva was only needed if the area was inflamed. Now, you have to remember what they were originally looking at was a smooth surface implant, where many of the cases were full mouth cases and the implant abutment junction was high and dry. When we started dealing with rough surface implants, what we found is significantly more peri-implant disease without keratinized tissue, and this was Block in 1996. So, peri-implant disease is multifactorial. There are implant-related properties as factors such as surface properties, the material used in the design of the implant itself, clinician-related factors such as the surgeon's surgical skill and the prosthetic skill of the restorative dentist, and patient-related factors such as predisposition to periodontal disease, systemic medications, oral hygiene, smoking, and bone quality. To me, the key thing that we have to deal with is we're dealing with a unique problem that we really never had to deal with before regarding peri-implant disease. And that's really the macro and micro geometry of the implant itself. The macro geometry of these threads with these concavities that can get debris into the concavities of the threads that make it really difficult to clean and get the bacteria out, and the microgeometry of the implant surface, where in this particular case you can actually see bacteria in the pores and concavities of this implant surface. Microbiology of peri-implant disease says the bacteria around teeth prior to implantation determines the composition of the microflora on implants. And the bacteria in periodontal disease are also present in peri-implant disease. And a key significant problem is implants are being placed in patients with active periodontal disease. Thus, the bacteria, the seeding bacteria, is already there. And the research shows patients who lost their teeth due to periodontitis have an increased risk of developing peri-implantitis. So if we look at this particular case here, you can see this patient in 1999 had a lot of bone loss around this tooth. The tooth was removed, the site was augmented, and the implant was placed in 2000. In 2004, that implant was still stable. But the patient, who was susceptible to periodontitis and a smoker, wound up moving to China. We didn't see him for 5 years, and when he came back, after smoking 3 or 4 packs a day, you can take a look and see the amount of bone loss around this implant. And in 2012, this implant, 3 years later, this bone loss had progressed a bit more. Histopathologically, we also have a problem, because it's been shown that the amount and intensity of bone loss around the dental implant is greater than around the tooth. Now, around the tooth, what we actually have is perpendicular connective tissue fibers inserting into the root of the tooth. Now, these perpendicular connective tissue fibers act as a barrier to prevent the downgrowth of inflammation into the underlying bone. Around an implant, we have no fibers attaching into the surface of the implant. So without these fibers, what happens is the bacteria tend to grow apically in a more aggressive fashion into the bone than they do around the tooth, where we have this connective tissue fiber barrier. And these studies by Lindy and Berglund in 1992 and 2004 show the apical extension of the inflammatory cell infiltrate was more widespread and extended into the alveolar bone around the implants, and the peri-implant tissues appeared less able to arrest progressive plaque-associated lesions. This is a photomicrograph of Dan Boozer's, and here you can actually see the parallel or circular orientation of the connective tissue fibers, and this may lead to a more rapid spread of inflammation in the peri-implant mucosa. So here are the connective tissue fibers approaching the implant, and when they get to the inner zone, this inner zone of connective tissue fibers, right next to the implant, turn and tend to go circularly around the implant. Now, really sobering statistics come from the work of Ludebaker and Klaus Lang, showed that the chances of gingivitis becoming periodontitis are 30%. Whereas the chances of mucositis becoming peri-implantitis are as high as 60%. This is a real problem. Now, this inner zone of circular fibers caused this aggressive bone loss around a dental implant that we just don't see around the tooth. And if you can notice, very often this circular bone loss, or the appearance of this bone loss, is symmetrical, because what happens is the inflammation follows the circular fibers around the implant, causing bone loss, and this type of bone loss that we, as I said, we don't see around teeth. Another problem is the rate of peri-implant bone loss increases with time. Thus, this patient had these implants placed in 2000, not a patient of ours, but she came into the office in 2008, and this is what the implants looked like radiographically. Now, in 2011, she had started to develop peri-implant disease, and we told her she needed treatment, and she got lost, and she didn't go through the treatment, but she returned again in 2014. And in 3 years, take a look at the aggressive bone loss and the rapid bone loss that had occurred around this implant. So peri-implant bone loss is not linear. It can develop and it can spread very rapidly. May not all the time, but when it does, it has the chances of developing and progressing very rapidly. This is a problem. So, in terms of definitions, growth of oral biofilm is facilitated by the design of the superstructure, and we all have cases like this that are almost impossible for the patient to keep clean, the screw-shaped design of the threads of the implant, and the surface modifications of the implant itself, and in other words, the surface texture of those implants. The weak links are the surface and the implant abutment junction. So in this situation where the tissue is flat back, you can see Heiss-Mayfield says the adhesion of microbes to bare and rough implant surfaces impedes mechanical cleaning. So if you take a look here, you can see we actually have plaque and calculus in the concavities of the threads of this implant surface. Now our normal scaling and root planing action is occlusal gingival. But going occlusal gingivally is not going to get into the threads of these implants. To get them clean, you essentially have to go circumferentially around the threads of these implants. And if I hadn't flapped this back and hadn't been able to visualize it, I wouldn't even know that this bacteria and this plaque and calculus were in the threads of this implant. The weak links also are the implant abutment junction. Now, there's plenty of research showing that micro-leakage occurs into and out of both the internal hex and Morse taper connections. And where more often than not is the implant abutment junction, but right at the crest of bone. And if you take a look at this picture here, you can actually possibly see this opening, and you can see in the video, when force is placed upon this implant, how the implant opening and the implant abutment junction torques, and bacteria tends to progress and work into this implant abutment junction. And this even occurs when torquing a Morse taper implant. Not as often, not as much, but there is an opening that's present around the Morse tapered junction. This is a problem. Cement is a real problem. In a paper by Wadwani and Pinero, they said 65% of 185 implants showed evidence of excess cement when examined under magnification. And you can see the existence of cement here, causing this fistula, and the presence of cement here, and this is what this implant surface looked like after this implant was removed. Now, as a periodontist, I would prefer that all your implant cases, whenever possible, are screw retained, because those are retrievable. If there's ever an issue, ever a problem, we can always remove the framework and the restoration and try to resolve the problem that may exist. Much more difficult with a cemented restoration. But if you are going to cement a restoration, and again, this comes from Wadwani and Pinero's group, the question is how you cement these restorations. Do you fully cement them? Do you partially cement them? Or do you just rim them? And they also came out with the concept of using a cementing die if you're going to cement your restorations. And with the cementing die is what you do is you take the final restoration and you put some dye spacer inside the final restoration or lubricant, and you put acrylic, quick setting acrylic into the restoration, and then put a dowel into the quick setting acrylic. Let it set, and once it sets, what happens is you have a die of this crown, of the inside or internal part of this crown. Now, what you do then is you take your cement, and hopefully it's a temporary cement, possibly a zinc-based cement, because zinc-based cement is more radio-opaque, and it's been shown to have some antibacterial activity or antimicrobial activity. So something like a temp bond into the inner aspect of the crown, and then you take the cementing dye, put it into the crown, and that will express any excess cement. You remove the excess cement and then take the crown and place it in the patient's mouth. This can also be done with an elastomeric impression material, where you put a dye spacer into the interior part of the crown, you put the impression material into the inside of the crown, wait for it to set. When a dye forms like such, you then put your cement inside the crown, you put the cementing dye into the crown, expressing the excess cement, and then you wipe off the excess cement. Similarly, this can be done with multiple teeth also, where you make the internal dye of these teeth, put your cement in, and then cement it and express the excess cement. But as I said, from a periodontist, the standpoint of a periodontist, I would prefer you didn't cement your cases, but screw retained your cases. The one thing we have going for us, and the positive, is that treating mucositis prevents peri-implantitis, because mucositis is reversible. So this is the key to what we're going to look at as we move forward. So once again, definition: mucositis is a reversible inflammatory infiltrate in the soft tissues surrounding a functioning implant. Its clinical signs are inflammation, bleeding upon probing, 4+ millimeter pocketing, possibly suppuration, but no progressive bone loss. So if you have 5 or 6 millimeter pocketing and you don't see any bleeding, what you have to do is you actually have to palpate and place pressure on this gingiva here to see if you see any suppuration. Because what happens at 5 to 6 millimeters is the aerobic flora becomes more anaerobic in nature. And that anaerobic flora is more destructive as far as bone loss around around dental implants. And you may very well, even without seeing bleeding around fibrous tissue, you may very well see purulence or pus coming out of that sulcus. As I said, part of the definition of mucositis: no radiographic or no progressive bone loss beyond the first year of loading. So this is what this case looked like in 2005, this patient. You can see the patient here in 2008 and in 2011. Still bone loss down to the first thread and no progressive bone loss. Now what the research shows is mechanical therapy alone is inadequate to predictably detoxify an implant surface. And here is, again, you've seen this picture before, bacteria into the pores around this dental implant surface. So the goal of treatment is surface decontamination, both mechanical and chemical, with the objectives being to disrupt the bacterial plaque biofilms, detoxify cell components affecting growth on the implant surface, reduce the bacterial load by dilution to a level that will allow healing. Now these are all basic microbiologic tenets, all right, that we learn in a first year of dental school when you take dental microbiology. Disrupt, detoxify, dilute bacteria in order to destroy bacteria. The goals of treatment are eliminate bleeding upon probing, reduce pocketing, and stabilize bone levels. This is what we're attempting to accomplish. Now what we need in order to accomplish this is we need a readily available, low-cost method to detoxify an implant surface. And the literature, the dental literature, has multiple studies showing multiple different methodologies of detoxifying an implant surface, from curettes and ultrasonics and air polishers to lasers and titanium brushes and chlorhexidine, and then medicaments such as sterile saline and sodium hypochlorite and citric acid and topical tetracycline and biologics, essential oil mouthwashes, triclosan, polishing cups and brushes, antibiotics, glow discharge, and photodynamic therapy. So in the literature, you can find a lot of different methodologies or methods of detoxifying an implant surface, and this is confusing. But Esposito sums it up so succinctly when he says, while there is no reliable evidence suggesting which is the most effective treatment for treating peri-implant disease, that doesn't mean that currently used treatments don't work. And the essence is they all, for the most part, do, to either a greater or lesser extent. So let's take a look at the most common instruments that we have in our offices and that we use in our dental offices. Curettes can be problematic, all right? They have to be softer than the implant. The metal of the curette has to be softer than the implant. Stainless steel curettes can alter the implant surface, and the damage to the oxide layer will affect the surface chemistry and the implant surface's biocompatibility. And surface roughness influences plaque growth. So you can use a titanium curette, and you can use it on the threads of the implant, whereas it might scratch the collar of the implant. You can use plastic curettes. You can use gold curettes. You can use fibrin-carbon curettes. A study by Hastricht, Journal of Dental Hygiene, showed a comparison of the implant scalar material composition. He looked at 6 scalars and 3 abutments, and what was found was unfilled resin was least damaging to smooth surface abutments, but the results were not applicable to rough surface abutments. So an unfilled resin plastic curette was relatively did not damage an implant surface. But as it turns out, it was at the least effective of removing biofilm, but it will disrupt the biofilm. So you can use a plastic curette to disrupt the biofilm, and then subsequently use some sort of chemical to wind up removing the biofilm once you've disrupted the biofilm. Now, many people use ultrasonics. Now, here's the problem with magnetostrictive or elliptical ultrasonics, such as a Cavitron. Ultrasonic scalars can cause considerable damage to implant surfaces. And this is a close-up of what happens after the ultrasonic instrument hit this implant surface once and it put a gouge in it. And this damage to the titanium oxide layer can lead to a change in surface chemistry and biocompatibility. So what happens is they came up with the idea of putting this Teflon tip on top of the Cavitron surface. And that eliminated the heat and surface damage. But what happened is this Teflon tip tended to flake off and shard when it was on an implant surface. And you can get shards of plastic dropping into the base of your defect, which will wind up causing a foreign body reaction and problems. So there's another type of ultrasonic that I'd like to tell you about, and it's a linear ultrasonic or a piezo ultrasonic scalar. And this is developed by the EMS company in Switzerland, and it doesn't gouge the implant surface the way the magnetostrictive or Cavitron or elliptical ultrasonic does. They have a peak tip for it, okay, that causes minimal scratching on the titanium surface, and this tip is designed for accessibility to get into the implant pocket or around the implant, and there's less patient discomfort. It's shown to be as effective as conventional ultrasonics, and it's used with either the Lanapp procedure and the LePip procedure, the ultrasonic. This particular EMS ultrasonic piezo is also used, and this tip is designed for accessibility insertion. Air power abrasives. Air power abrasive can successfully decontaminate an implant surface, but there's an increased risk of air emphysema. Sodium bicarbonate can cause microscopic damages to the implant surface, and sodium bicarbonate can lodge in the concavities in the implant surface itself, and that's been shown. So as an opposition to a sodium bicarbonate air abrasive, here's an option also by the EMS company. It's called the PeriFlow, or the Airflow PeriFlow. And what it has is it has a plastic subgingival tip that can insert into the pocket around the implant. And there are 3 openings to the powder that comes out of this air polisher. And what happens is it uses a glycine powder that comes out laterally and cleans both the soft tissue and the implant surface, with water coming out apically. And as I said, it uses a glycine powder. So glycine powder is an amino acid, and the amino acid is going to be soluble in the oral environment and oral fluids. And this instrument also works at a reduced air pressure with reduced compressed air. The results have been shown to be comparable to hand instruments, the lasers, and photodynamic therapy. There's a lower risk of air emphysema. There's no residual or surface damage as opposed to sodium bicarbonate, and superior biofilm removal than a curette, rubber tip, and prophy brush. As far as the lasers are concerned, the lasers have gotten a lot of publicity. Lasers will remove bacteria and reduce bleeding upon probing. But the things that we don't know are heat from a laser can cause surface damage and changes to metal, and you can get a change in the hydrophilicity on the implant surface, and carbon residues can accumulate on the surface. And the answers we still need are what's the most useful, an ERGAG, a CO2, a diode, or an Nd:YAG, as well as the optimal power settings and wavelengths for achieving the reduction of the bacteria. And we want to know the effect on implant surfaces and the surface alterations. Now at Columbia, we're very fortunate. We have an ERGAG, we have a CO2 YAG, we have a diode, we have a chromium ERGAG, we have faculty members that have access to the Nd:YAG, and I must tell you, I like using lasers. Every time I've used it with my students, I've gotten positive results. The thing is, a laser costs $100,000. And a dental practitioner in a small town in Eastern Europe or in South America or in Asia or in the United States, for that matter, is just not going to spend $100,000 on a dental laser to detoxify an implant surface. So we have to find another way. Now, looking at a graph by Schwartz summarizing a lot of his research, interestingly enough, shows the glycine powder out of an air polisher showed the least amount of residual plaque biofilm when compared with all of these other possible techniques, which I found very interesting. So, as I said before, a readily available low-cost method is needed to detoxify an implant surface, and an easy-to-use in-office and at-home regimen is needed to help maintain a patient's mouth. So what are we going to use in order to detoxify the implant surface? Well, we're going to use something called cumulative interceptive supportive therapy, or CIS, that was originally developed by Lang and Monbelli back at the late 1990s, and they worked on it again in the early 2000s. And this approach is a cumulative approach. It's an incremental, accumulative approach to dealing with the presence of Peri implant disease. And what you're going to do is we're going to do is start with mechanical therapy first. If mechanical therapy doesn't solve the problem, or it doesn't respond to mechanical therapy, we're going to add antiseptic therapy, or treatment B to the whole protocol. And if it doesn't respond to antiseptic therapy, then we may get involved in adding antibiotic therapy, and then finally involved in adding surgical therapy. So if we take a look at this chart on the right here, with pocket depth 3 millimeters or less, and no plaque and no bleeding upon probing, there's no treatment or just polishing. If there is plaque, we remove the plaque, even with a little bit of bleeding upon probing at 3 millimeters or less, and we mechanically debride and polish. That's simply treatment A. When we get down to 4 or 5 millimeters, in addition to treatment A, mechanical debridement, we add treatment B, which is antiseptic cleaning. And the question is, what do we use to add chemically or antiseptic cleaning to help clean this implant surface? When I ask this question when I speak, most people say chlorhexidine. Now, chlorhexidine is good, but chlorhexidine has some problems. Chlorhexidine is most effective as an intraoral mouthwash because of its substantivity. So it gets on the mucous membranes, it gets on teeth, and it will stay there. The problem is chlorhexidine is inactivated by ingredients in toothpaste. It's not very effective interclavicularly. It's inactivated by the serum proteins. You can wind up getting a deposition of a dense, stable film or hydrocarbon and carbonate film on the implant surface. In vitro, chlorhexidine affects osteoblastic response irrespective of antimicrobial effect. So even if it kills the bugs, it does affect the osteoblasts in vitro in terms of their regeneration. And it's also been shown to suppress the proliferation of fibroblasts and collagen produced by the fibroblasts. And finally, it may prevent reintegration in peri-implantitis. And this is Crozier's work back in 1999. Other people will say peroxide for chemotherapeutic decontamination. And peroxide's good. It's an oral debriding agent and wound cleaner in low concentrations on a daily basis. There's no adverse changes. You have to utilize it in conjunction with mechanical debridement, according to Dunlap. And what they've also found is peroxidase and catalase and the antioxidants in the body will break down peroxide rapidly. So that's the problem, because whenever you see the bubbles, that means its activity is over. Finally, iodophores, another antiseptic used, and very effective. It's bactericidal, fungicidal, and virucidal. It's non-toxic or irritating to the mucous membranes, and it kills all bacteria in planktonic growth. Planktonic means just a flat, single surface or single layer of cells or bacteria, but not possibly in a biofilm, which has multiple layers, and it has a whole colony. So we don't know for sure. The problems with betadine or povidone iodine is it's activated by blood and sputum. It has to stay on the surface for at least 5 minutes, and it may cause an allergic response. People that are allergic to shellfish can get allergic response for this. So what we are talking about using is sodium hypochlorite or household bleach, but a reduced solution, a 0.25% solution. Clorox is 6% normally. Now they have a concentrated solution that's 8, but we're going to use a 0.25% solution. And a 2.25% solution is still shown to be highly cytotoxic. There's an 80-fold decrease in biofilm endotoxin when compared with water. It's found naturally in macrophages and neutrophils, so it's not going to be carcinogenic. There's no visible histological effect on periodontal healing, and it does not corrode titanium implant surfaces. And even better yet, it's been accepted as a safe mouthwash by the American Dental Association. So this has a lot of positive things going for it. The question is, how do you mix a 0.25% solution of sodium hypochlorite? Well, what you do is you mix 5 mLs or 1 teaspoon. Okay, you can get a syringe with 5 mLs, 10 ml syringe, take up 5 mLs, which is also equivalent to 1 teaspoon. If you want to use a teaspoon of household bleach, in 4 ounces or 125 milliliters of water. Now, the standard size drinking cup in the dental office that most all of us use is 5 ounces or 156 milliliters of water. So what you essentially have to do is take 5 milliliters of household bleach and put it in the dental drinking cup and fill the cup 4/5 of the way with water, and you will have an approximately 0.25% solution of sodium hypochlorite. And what we're going to use is either a blunt monojet syringe or a monojet syringe with a blunt 27 gauge needle to get around our dental implants, or this is a plastic curette or a plastic tip that's been used by a bleaching tray, okay, Ultradent bleaching trays. And this is the Ultradent bleaching syringe, and it's a plastic syringe, and it's malleable, and it will get underneath the gum into the area that you want to irrigate. So that's what we're going to use for antiseptic cleaning. Now, what you're going to do after that is you're going to send the patient home and give the patient a home care regimen, which we're going to talk about. And when the patient comes back in 3 months, or if the patient has 5 millimeter or greater pocketing, what we're going to do is we're going to put an antibiotic into the mix and add that to treatment A, which is mechanical cleaning, and treatment B, which is antiseptic cleaning. So, as far as antibiotic therapy is concerned, what we use is we use a local antibiotic wherever possible, with the theoretical advantages being a higher concentration delivered right to the site, reduced risk for adverse side effects, reduced interaction with other drugs, reduced risk of emerging antibiotic resistant strain, and it's not dependent upon patient compliance. These are all good things. And the local antibiotic we've been using is a minocycline microsphere or Arrestin. Now, what Klaus Lang says is what you need is 100 times the minimum inhibitory concentration for 6 to 8 days in order to kill the bacteria associated with Peri implant disease. Minocycline microspheres give you 1,000 times the minimum inhibitory concentration for 5 or 6 days, and it's still more than 100 times the minimum inhibitory concentration for 14 days. So this really kills the bugs that contribute to peri-implant disease. You see improvements in pocket depth, bleeding upon probing, and microbiology at 6 months, but not 12 months. Now, we don't need this to be successful or active for 6 months. We only need it to be active for 3 months when we're going to see our patient again and re-disrupt the bacteria again and retreat and re-irrigate to disrupt the bacteria to keep it below an inflammatory concentration. Now, improvements in pocket depths are only in the range of 1 millimeter. So you don't see a lot of pocket depth improvement here, but what you do is you do see a significant change in bleeding upon probing and the microbiology. Finally, after going through all of that, if the patient is still losing bone, you get involved in resective or regenerative therapy, and you go to treatment D. So let's take a look at this in chart form and summarize exactly what we're going to do. At 3 millimeters and no bleeding upon probing, you gently probe for resistance, and you do have to probe your cases. The early Brandemark research said probing didn't matter and you don't have to probe your cases. You do have to probe your cases because bleeding upon probing is one of the best indicators that we have for the presence of inflammation. You also evaluate plaque levels, and then you prophy cup and clean at 3 millimeters. At 4 to 5 millimeters and no bleeding upon probing or suppuration, again, you mechanically debride, you curette, you can possibly use a linear air polisher, all right, or you can use an air polisher with glycine powder or a linear ultrasonic, the Piazon that we discussed. Hygienists like using these instruments, especially to get around frameworks that are heavy and over-contoured or crowns that are thick and over-contoured. Now, at 4 to 5 millimeters with bleeding upon probing, or greater than 5 millimeters with or without bleeding upon probing, or suppuration on probing, you get involved in interceptive therapy. And what you add in this case is your antiseptic, which in this case is sodium hypochlorite, and you irrigate before, during, and then after debridement. All right, so you irrigate before debridement to disrupt the bacterial biofilm. You get in there with your curette or plastic curette or titanium curette to try to remove some of that biofilm. Then you irrigate again to flush it away and wash it away. And then finally, after total debridement mechanically, to again further wash it away. Then what you do is you apply pressure right on the gingiva, right at the margin of the gingiva where it meets the implant and where it meets the restoration. And you do this in order to try to get a primary clot and get a clot of that soft tissue to the surface of the implant. Gingiva will adhere, or epithelium will adhere to any smooth surface, a clean, smooth surface, and what we want to try to do is to try to get this epithelium to readhere to this clean, smooth surface. You then send the patient home and you give them a home care regimen. And you have a talk with the patient. You have to let them know controlling the biofilm is critical over the next 3 months, and that's their goal, that's their job, with the objectives being to minimize subgingival migration of the supragingival biofilm and to keep the subgingival biofilm below an inflammatory concentration. And what you have to do is you have to explain to the patient. And I find my implant patients to be a lot more compliant than my periodontal patients. My implant patients have already lost their teeth. They spent a lot of time, effort, and money trying to save their teeth. And now you're telling them they're in danger of losing their teeth, losing the implants that they've had put in. And they're very compliant and very acceptable to doing whatever you want them to do. So how are they going to keep their mouth clean? Well, optimal home care is imperative. And what you have to explain to the patient is you've disrupted the subgingival biofilm, and it's now their responsibility to stop the supragingival biofilm, or the biofilm in their mouth, from migrating subgingivally and reaching an inflammatory concentration. And in order for them to do that, you're going to try to keep it as simple as possible. You're going to ask them to brush their teeth, and you're going to ask them to rinse their mouth out with a mouthwash. To brush their teeth, they're going to use a triclosan dentifrice, which is Colgate Total. There's reduced inflammation, bleeding upon probing, and 5mm pockets, reduced pocketing over 6 months. A lot of research on Colgate Total with triclosan. Less plaque reduction in gram-negative anaerobes over 6 months, and there's no evidence of negative effects over 20 years of data. So they're going to brush their teeth in the morning and once before they go to sleep with Colgate Total toothpaste with triclosan. And then twice a day they're going to use an essential oil mouthwash, which is Listerine, which, as it turns out, is the best non-prescription anti-plaque mouthwash on the market. And plenty of research showing less plaque and bleeding upon probing than controls. Little change in pocket depth, though. If they don't want to use an alcohol-based mouthwash, they can use Listerine without alcohol, or a CPC mouthwash, such as Colgate Total mouthwash, which has total 12 hours of substantivity, no alcohol, and this is acetylpyridinium chloride mouthwash. So they're going to brush with the triclosan toothpaste twice a day. One of the brushings being right before they go to sleep at night. They're going to rinse with an essential oil or CPC mouthwash twice a day, with one of the rinsings being right before they go to sleep at night. They're going to use floss, possibly, and we'll talk about this, an end-tuft brush or interproximal brushes, if you can get them to use it, either better. And around larger frameworks, you're going to ask them to use sodium hypochlorite in a monojet syringe or in a water pick 3 times a week around the frameworks in order to try to keep these frameworks clean. And what you're going to tell them to use is 1/2 teaspoon of sodium hypochlorite, which is 2.5 milliliters, in 16 ounces of 500 milliliters of water. And you can do this in a water pick reservoir, a large water pick reservoir, or they can mix it in a glass and put it into a plastic monojet syringe if you give it to them. Now, as far as using floss is concerned, and interproximal flossing and superflossing, Veldin just recently came out of a study looking at 10 patients with Peri implant disease and found excess floss or residual floss caught in the threads of the implants subgingivally. So this can be a problem, and you have to be really careful with telling them to floss. Now, what you're going to do is you're going to see the patient at 3 months. They're going to come back in again. And if they have 4 to 5 millimeter pocketing and bleeding upon probing, or greater than 5 millimeters with or without bleeding upon probing, you're going to repeat the initial therapy, and you're going to add local antibiotics or minocycline microspheres in every pocket around that implant that's 5 millimeters or greater. And then you're going to apply pressure. After you're doing the initial therapy, you're going to repeat the whole initial therapy of A, B, and C, and then add local antibiotics or minocycline microspheres around the implant, all right, wherever you can. Apply pressure and send the patient home, and then bring them back at 6 months. Now, we did a study at Columbia University looking exactly at this protocol, and it was done by one of my residents, Al Lee, myself, and the chairman of the department, Panos Papapanos, and we looked at 35 patients with 35 implants. We looked at 6 sites around each implant, or a total of 210 sites, And what we found is initially at baseline, as far as beating upon probing, the cellular bleeding index was 1.43. At 3 months after initial debridement, it had decreased to 0.61. And in the situations where we subsequently had to use the minocycline microspheres, at 6 months it had decreased to 0.19. Same thing with pocket depths. We saw a decrease in pocket depths. 4.5 millimeters at baseline. After 3 months, we went down to 3.5 millimeters, and at 6 months, 3.14 millimeters. So this is pretty dramatic. And what we saw, if you take a look at this graphically, this is the number of sites that had bleeding upon probing, that had no bleeding upon probing initially. All right, it's about 35% of the 210 sites. After 6 months, 61% of the 210 sites had no bleeding upon probing, and then after 3 months, 61% of the sites had no bleeding upon probing, and after 6 months, 89% of the sites that initially bled upon probing had no bleeding upon probing. So the crux of the information here is if you clean the surface of the implant, good things will happen. You bring the patient back at 6 months, and if there is no resolution, well, then your alternatives are to put the patient on systemic antibiotics, remove the restoration and detoxify if it's a screw-retained restoration, and I'm going to show you that and talk about that, and surgery if progressive bone loss is occurring or the patient is prone to periodontal disease. So, as far as systemic antibiotics are concerned, the rationale is to reach and affect gram-negative bacteria invading the peri-implant tissues. And what we'll use is we'll use amoxicillin 250 milligrams 3 times a day for 8 days, along with metronidazole 250 milligrams 3 times a day for 8 days. If the patient is allergic to amoxicillin, we change to Cipro 500 milligrams BID, along with metronidazole simultaneously 500 milligrams BID for 8 days. And this is Jorgen Slotz's research and work and recommendations, and we follow that in this particular situation. If the restoration can be removed and detoxified, we would much prefer to remove the restoration and detoxify it. What we'll do is take off the prosthesis as feasible, and we'll remove the plaque by burnishing it with a cotton pellet with sodium hypochlorite. We'll steam clean the underside of the restoration, use a ProfiJet to detoxify it or even sterilize it, and also use a cotton pellet to detoxify the platform of the implant along with the screw access opening, and then we'll gently curette the pocket lining to remove the epithelial pocket lining, and then replace the restoration and apply pressure at the gingival margin of the restoration for 1 minute continuously in order to try to get epithelial readherence. And this is this case that we've been looking at all along, and this is the pre-op of the case. And as you can see, at 6 months, the inflammation is gone. The pocketing has been reduced significantly, and for all intents and purposes, the bleeding upon probing has been eliminated. Here's another case. Patient had 7-8 millimeter pockets around this second molar. Now the tissue can be very thick. You can even start with 5 millimeter pocketing around the second molar, but when we take this off, you can see here, you can see the amount of debris and material that's underneath, this restoration sitting on the soft tissue. Now this is a nightmare waiting to happen. And this patient still is considered to have mucositis because this is a sinus-lifted area, but there's really no bone loss per se around the implants at this time. So what we'll do in this case is, and here you can see why we were probing 8 millimeters, you can see the inflammation in the sulcus in this area with mucositis, even though it was 7-8 millimeter pocketing. But we'll lightly curette this, we'll detoxify the implant abutment opening and the platform of the implant with sodium hypochlorite, and we'll burnish the underside of the restoration and clean the underside of the restoration with either sodium hypochlorite or peroxide, and then replace the restoration and again apply pressure for 1 minute continuously. And at the 1 year follow-up, you can see we're still probing 5-6 millimeters around this implant. But as I said, the tissue can originally start at 5-6 millimeters in the tuberosity area. But most importantly, there's no bleeding upon probing at the 1-year follow-up. And finally, here's another case with a framework. Now, we all have cases like this, and we know it's impossible for the patient to get under these restorations in order to keep these clean. And here this patient had a peri implant abscess around the soft tissue around this implant. So we remove the framework, and you can see the inflammation around all of these implants, including the reason why the patient had an abscess around this distal implant. So we detoxified the screw access openings here. You can see what the underside of the framework looks like here, and the plaque on it and what have you. And we clean everything we can possibly clean with sodium hypochlorite, going around and into the screw access openings and clean the acrylic, go in at the implant abutment junction and onto the platform or the top of the implant into the internal connection. We'll actually relieve the framework on that partial, put everything back in the patient's mouth, and at 3 months, this is what the follow-up looks like. Now, as it turns out, we had to remove this framework for a restorative repair or a prosthetic repair, but it allowed us to look at the soft tissue around these implants, and you can see how the inflammation has been resolved. Now, when I speak, I say this isn't magic. This is purely microbiology and understanding bacteria. And if you get rid of the bacteria, good things will happen. Now, if you can't remove the frameworks, how do you detoxify around a situation where you can't remove the frameworks? Well, you can see here the inflammation around this implant, but it's still mucositis. And here we use the Piezon tip, and we happen to use the Peri flow to thoroughly clean around this restoration and implant and apply pressure for 1 minute continuously. And this is the 1-month follow-up, and you can see at 1 month the type of resolution you have the potential to get. If the crowns are in place and you can't get around the crowns, you can see what the implant surface looks like here, along with the plaque present and on the palate. And again, here we got in with an air polisher and the subgingival tip of the airflow polisher to clean this area thoroughly. And then we irrigated thoroughly, in this case with sodium hypochlorite and followed by peroxide. And you can see how much cleaner the implants look after you clean and debride under there. It then becomes a question of the patient maintaining these areas. And with big frameworks in place, these are almost impossible to get around. But what you try to do is get in with a curette as best you can, and then irrigate as best you can, and have the patient use the sodium hypochlorite in the water pick 3 times a week in order around these frameworks in order to clean them. Now, if after all of this you still see progressive bone loss or the patient's extremely prone to periodontal disease, you get involved in treating the area periodontally with periodontal or peri-implant surgery, with the treatment goals being, again, to detoxify the implant surface and to try to reduce the pocket to 5 millimeters or less to optimize the maintenance of these situations. Now, there are many, many different techniques, multiple techniques, in order to, as far as surgical approaches to peri-implant disease is concerned. But as far as time is concerned, because due to time limits, I'm just going to speak about one or mention one to you, this minimally invasive surgical technique that I've been working at called COAP. And COAP stands for Circumferential Occlusal Access Procedure. Now you can take a look at this case here, and we had originally did these in incipient peri-implant disease cases, and as I saw the procedure working, I wound up using them in more and more involved cases. So if you take a look here, again, 8 millimeter pockets around the implant. This is the bone loss around the implant, and again, pocketing on the mesial. What we wind up doing is we wind up removing the implant restoration. And again, like that prior case, you can see what's going on when you remove this implant restoration. And all too often, this is what you see. All this debris, and look at the contamination on the platform and in the implant abutment junction, in the implant attachment apparatus itself. and take a look at the underside of the restoration. And this is a horror show. It can become a horror show. So again, what we have to do in this case is we remove this inner ulcerated clavicular epithelial lining. And here we're using a 15C scalpel. We can also use a microsurgical blade. And what we want to do is we want to remove this inflamed tissue and bacterial-filled tissue to expose the head of the implant. Now, once you've exposed the head of the implant, you can do anything you want in order to detoxify the implant, ahead of the implant, and clean the implant surface. Notice, no flap. No flap, a minimally invasive surgical procedure without a flap. First thing we do is we wind up irrigating, or we wind up actually on a cotton pellet. We irrigate, and we use a sodium hypochlorite on a cotton pellet to detoxify the implant surface and also loosen the biofilm so that we can remove it easier mechanically. So we go around with a cotton pellet, and then we take plastic curette to clean the smooth surface of the implant collar, and then we get a bit lower and we go along the threads of the implant with a titanium curette, going circumferentially into the threads of the implant, and also we clean out the infrabony defect pleasant, and we feel the anatomy of the infrabony defect. Additionally, while we're cleaning this out, what we'll do is we'll take a mini elevator or a micro elevator that we also use, for instance, in a tunnel procedure. And we'll use that micro elevator to lift the gingiva away from the plate of bone on the palate, in this case, and on the buccal. So we're lifting and reflecting this tissue off of the plate of bone or off of the bone on the buccal, palate, and interproximally. And then we're cleaning the surface of this bony defect, feeling the anatomy of the bony defect. Then we'll go back in and irrigate again in order to clean a bit more with our sodium hypochlorite irrigating solution. And then after all of that, what we'll wind up doing is taking a membrane, and this happens to be a porcine membrane, and what we use here is a tissue punch, and this is a 4mm tissue punch. And we put a 4mm diameter opening using the tissue punch into this membrane. Now the implant is 4mm in diameter. The diameter of the tissue punch is 4mm of diameter. So we're going to take that ultimately and set it aside, and then we take some bone. In this case, we're using bovine bone, and we're incrementally packing this bone into the infrabony defect, coming up right to the top of the defect and trying not to overfill the defect and keeping it in the contained infrabony defect. After that, we take that membrane that has that 4mm in diameter punch, and we take it and place it over the implant, and we tuck the edges between the flap of tissue, or the palatal flap of tissue, and the crest of the bone, and we tuck it around on the palate, interproximally, and here you can see this buccal edge of this membrane, and we're going to take this buccal edge of the membrane and put it underneath the tissue on the buccal and pack it between, or place it between the tissue and the bony wall on the buccal. And we do that circumferentially around the implant, covering that bone graft. We then go back to the restoration, and we clean everything we possibly can on that restoration. The underside, the screw axis opening, the screw itself, and we do that again with sodium hypochlorite and peroxide. We then take the restoration, place it back in the patient's mouth, and here you can see it's screwed back into the patient's mouth. And notice, no sutures. We subsequently apply pressure, buccal and lingual for 1 minute. We remove this removal button, and when you take a look at the postoperative x-ray, no sutures, flapless, no sutures, you can see the bone around this implant. Now, this is the 10-week healing. At 10 weeks healing, we still have, as you see, we have about a 6mm residual pocket depth. And with this 6mm residual pocket depth, again, the tissue is very thick here and can be 5mm to start, but the key thing is no bleeding upon probing at 10 weeks, and we still have bone in place. At 8 months, still 6mm pocketing, no bleeding upon probing, bone still in place. So this is COAP, or the circumferential occlusal access procedure, and we've been using it and getting some very good results. So I'm going to stop here, but I want to spend a minute talking about radiographs as far as their importance in early diagnosis in disease, at final placement to establish a baseline, final placement of your final restoration to establish a baseline, at 1 year post-loading, and you don't want the bone loss to exceed 2 millimeters. And then after that, you only have to take radiographs or subsequent radiographs if you start to see the pocket depth increasing during your maintenance visit. And what I would suggest you do, if you're a restorative dentist, send a copy of all the radiographs to your retreating surgeon if you didn't place the implant yourself. And that way you have the retreating surgeon also participating in the discussion of whether or not the patient is getting progressive peri-implant disease or not getting progressive peri-implant disease. Now, I'm going to end here, but as far as the treatment of mucositis and peri-implantitis is concerned, the best treatment for peri-implant disease in 2017 is prevention. Early antiseptic treatment is imperative, especially in the patient prone to periodontal disease, and treating mucositis prevents peri-implantitis. Once again, I'd like to thank Dental XP for producing this video. I'd like to thank you for your time, and I hope you found the information in my presentation informative.